Welcome back to the day 2 of PeachJAM. Can you hear me well? Yes. Okay. It's wonderful to see you all here this morning. Yesterday was such a special day. It was wonderful to see you guys connecting not only during the sessions over the beautiful cocktail and the dinner time. I also want to thank IgG4ward Foundation for the great honor for the amazing award I received. I was humbled and deeply grateful to be recognized by the community that I care so much. So we have another exciting day ahead of us, filled with learning, sharing, and connection. Let's get started. So before doing that, I wanted to also mention and acknowledge again generous donors and sponsors who made this possible for us. We do have a Q&A session at 9:30. So we try our best, Dr. Snow and I, who will run the first session, to answer your questions. But if you have questions that are not answered during our session, definitely write them down. We have baskets in the back that you can put your questions there, and we will try to answer them actually with other doctors, experts on the stage at 9:30. So definitely place your questions in the basket. So we will start today's session with applying clinical trial results to practice. How should we treat IgG4-related disease in 2026? So that's the big question. So now we know what is the standard of care and what we are doing, but what are the changes that are happening is also important. So before going there, I want to start with talking about what is the purpose of treatment for IgG4-related disease. We talked yesterday mostly about the road to diagnosis, how the journey to get to the diagnosis of IgG4-related disease has been very difficult and not as straightforward for most of you. But we're going to talk about the challenges of treatment of this condition. So the purpose of treatment in IgG4-related disease and most autoimmune diseases that have inflammation, and then the inflammation can go on and cause damage and scar tissue, is actually in two sections. The first part is reduce the inflammation, which is like extinguishing the fire that is happening at the organ. So we call it in medical terminology induction treatment. And most of you have received that when first they made a diagnosis of IgG4-related disease for you. You were given prednisone, steroids, sometimes when you were in the hospital through the IV, sometimes pills to just calm down the inflammation very quickly. But after that, what comes is maintenance therapy, which means to protect organs, to make sure you don't have another flare in that organ, so prevents damage and scar tissue, so you don't get those flares again. So what guides doctors to choose which treatments they do for you? There are three different factors that really influences the decision that the doctor makes. Some of it comes from experience, so rheumatologists or other doctors who have treated inflammatory diseases, that inflammation in the organ causes that. Without even clinical trials, they try prednisone, because prednisone is one of the most effective things that reduces the inflammation. So experience of the doctor treating and taking care of these patients influences their decision. The most important evidence that we use in science and in medicine to treat patients are the clinical trials and evidence that comes from research. Because without that hard evidence that if this drug works for the patients and how it works for them compared to if you don't use that drug, you can't really for sure prove the efficacy and effectiveness of the medications. And then patient's experience. So yes, we know prednisone works for some of you, but you may have had bad experience and you don't want to do that. So that definitely influences the decisions that I make about my patients. So I want to review what evidence we have right now and what has impacted the decisions that we do during the day-to-day practice in our clinics. So the induction treatment so far, based on the evidence that has been in the literature and mostly from consensus of the expert opinion, has been when the patient comes and has significant fire in an organ, you give them the prednisone, glucocorticoid. And lots of studies have suggested that it works as an anti-inflammatory, quickly reduces the swelling of the organ and inflammation that is there immediately. In 95 to 100% of patients with IgG4-related disease, the disease responds to a steroid treatment. And it's been actually one of the criterias to make sure that the patients who we diagnose them with IgG4-related disease, if they didn't respond to the first couple of weeks or a month of the steroid treatment, we should consider to rebiopsy them and consider another diagnosis, because cancer doesn't respond to a steroid, but IgG4-related disease responds swiftly. So this has been mostly used as the induction treatment. But glucocorticoids have significant side effects. Majority of you can actually tell me over here the side effects that you all have experienced from it. In the first few weeks or days, patients develop weight gain, increased appetite, significant mood changes, difficulty sleeping, increased blood sugar, blood pressure, fluid retention, you can name it. But more importantly, after patients are placed on the prednisone for long, months and sometimes years, hopefully not, the bone density drops, so they develop osteoporosis. They have increased sugars, they have increased risk of infection, cataracts and glaucomas develop, and skin thinning and bruising, and cardiovascular events increase. Heart attacks and strokes are increased because the blood sugar is high, blood pressure is high. So we have seen this firsthand in rheumatology clinic with other autoimmune diseases, and we see it in and out for patients who are referred to us and have been on a steroid so long. And we have been thinking of what else can we do to even avoid that induction treatment with the prednisone. So after induction treatment, what do we do in terms of do we keep them on something or just stop the 8 weeks of the prednisone that majority of the clinicians in the United States do? The studies that we have done, clinical research that have showed over the years, when we follow patients after taking them off the prednisone, about 70 to 90% of the patients experience relapse within the 3 years after they stop their prednisone. 7 out of those 10 patients can have continued flares, back-to-back flares. And as you can see in this schematic over here, so whenever these flares happen, damage can happen in the organ. With each time that you have pancreatitis, your pancreas gets scarred and atrophied. So with next flare, if it's in the kidney, if it's in the pancreas, may put it more at risk of to having the organ failure. So we don't want that to happen. Even if the prednisone induced the remission and you went to remission, we want to make sure that's not happening. So it's not that everyone needs to go on maintenance treatment. We have to make a decision, as we talked yesterday. Each patient is different. So there are some patients that I do not put them on maintenance treatment because we don't have very safe medications available. I mean, we have safe medications, but not something that if patient does not need it, I don't want them to be on. You heard from Dr. Stone about side effects of all the medications. So none of these medications are trivial. We have to choose a specific patients who need to go on maintenance treatment. So who are those patients who 70 to 90% will develop flare? So the way that we have seen it in the clinical trials and cohorts that we follow are patients who have main organ involvement, critical organ involvement, which is any organ that is shown over here, kidney, pancreas, lungs, retroperitoneal fibrosis, or aorta, organs that if another flare happens may cause the failure of that organ. I don't feel comfortable not to put them on maintenance treatment. But if the patient has only salivary gland involvement, parotid, it depends. If it's going to cause damage to the organ that causes significant dryness of their mouth, I may decide to put them on maintenance treatment. But if it is something that is really more cosmetic than anything, and The good news about the glands is if they flare, it's very obvious. They see it in the mirror and they call me right away. So I may choose not to put them on maintenance treatment and just wait and definitely see them every few months, make sure that the labs and blood work and everything else is okay, and decide whenever it's needed to put them on the treatment. So there are other risk factors that helps us decide who are patients that definitely from the day one, we need to put them on maintenance treatment after the induction treatment. Those are people who have multi-organ involvement. When most of you have seen your doctors, initially when we evaluate you, we do CT scans of your chest, abdomen, pelvis, in addition to examining your head and neck. So if you have more than one organ, the chance that you may flare in future is really high. If you had previous flares, the chance that you flare is really high. Patients who have elevated serum IgG4, serum IgE, or low C3, C4, which are complements, these are markers that we have found are associated with increased risk of flare. So those are people that we decide to put them on maintenance treatment. So what maintenance treatments do we use? The data that initially we had was from Asia. In Japan and China, low-dose steroid therapy has been used for maintaining patients in remission. So after they get the patients treated with high-dose steroid for about 8 weeks, they keep them on 5 to 10 milligrams of prednisone for years, for 1 to 3 years sometimes, to make sure that they don't flare. In some patients that works, but as we saw in my slides, staying on prednisone for years is associated with significant side effects. So we in the United States try to stay away from this maintenance treatment. Conventional steroid-sparing agents, as you heard from Dr. Stone yesterday, are available for autoimmune diseases, and we use them frequently for other conditions. The data in the literature is very confusing. So most of the prospective studies, means that the studies that the doctors treated these patients in their clinics and then wrote it up and made it available for public, show that majority of the patients on methotrexate, azathioprine, or mycophenolate require to stay on low-dose prednisone. So it's not much different from the one above that. So these steroid-sparing agents do not have that much efficacy to keep the flares of IgG4-related disease away. And that's why the targeted biologic therapies have become more interesting in this disease. So again, you heard yesterday about Rituximab. Rituximab is a monoclonal antibody that targets B cell. On the B cell, there are these markers, the proteins. One of them is called CD20, and Rituximab attaches to the CD20 and makes your own immune system to deplete or get rid of the B cells. And it's like a precision sprinkler. If we use the analogy of using like a fire extinguisher for prednisone, so this one is something that is just precisely affecting the part of the immune system that is causing IgG4-related disease. So Dr. Stone and I saw this patient that you saw his picture yesterday in my talk in 2009. He was treated with prednisone and methotrexate for many years, and he had diagnosis of Sjogren at that time with no resolution of his symptoms. He had to stay on prednisone for many years. And we were thinking of what can we do to improve his symptoms and try to get him away from the toxicity of not only prednisone, the methotrexate that he was experiencing. Looking at the pathology of the tissue, the glands that he had, we saw a lot of B cells in this tissue. So Dr. Stone suggested that we do Rituximab. And we treated him with Rituximab, and that's how you see him after Rituximab treatment. We wrote the first paper on the Rituximab treatment in 2010, and after that, a clinical trial on Rituximab open label that we can discuss in the next session what that means. was done. And after that, multiple clinical trials, prospective and non-randomized and retrospective, were done all around the world and showed that rituximab works. 97% of the patients respond to rituximab, and the disease goes to remission for a long term. In some patients, they may require every 6 months, so allowed tapering of their steroid, and that's how rituximab became standard of care. And many of you have received rituximab for the treatment and staying in remission, and can witness that it worked for you. So we had experienced that, of course, rituximab has some weaknesses too. So it's a chimeric monoclonal antibody. One part of it comes from mice. It does have some infusion reactions. In some patients, the length of B-cell depletion does not stay long enough, but we knew that mechanism works. So there was another B-cell depleting medication that was tried in this study, and Dr. Stone is going to go through the clinical trial and the studies of Inebilizumab that you all have heard, which is another B-cell depleting agent, upgraded type of rituximab. So I'm going to let Dr. Stone continue.
Okay, so the great news is that we have more choice now for treating IgG4-related disease, and we're going to have more choices in the future. And with more choice comes more complexity. We're going to go from the Pythagorean a squared plus b squared equals c squared to x cubed plus y cubed. Lots more things to think about. And at the time of the first Jamboree in Virginia, these data were not out. The paper was published just a few days after the Jam, and we haven't had a chance to discuss these data in public with you. So it's important to begin to have a conversation in the IgG4-related disease community about translating clinical trials to clinical practice. So can I anticipate that the drug as used in this trial will work for me in clinic, in my life? So this was the trial of Inebilizumab. These schematic designs of trials are a little bit complicated, so I'm going to take you through it slowly. They're not that complicated, but you just have to be oriented as to what's being shown. So there were 2 treatment groups in the Mitigate trial. There was the Inebilizumab group, and there was a placebo group, randomized double-blind placebo-controlled trial. Patients were randomized evenly into one group or the other. In order to be in the trial, patients had to have a flare of their disease. And to get into the trial, there were certain screening tests that the patients had to go through to make sure that they were eligible for the trial. During this time, they needed to be treated. So they were treated with steroids. Every patient was treated with steroids during the screening period. And they had to be down to 20 milligrams of Prednisone a day right before the first infusion of either Inebilizumab or placebo. Both of the treatment groups received 3 infusions during the trial. They received 2 infusions at the start, days 1 and 15, and they received another infusion at 26 weeks. And then the primary endpoint was measured at 52 weeks. The primary endpoint was disease remission off steroids, sustained disease remission at 52 weeks. And both groups received steroids, and the steroids were tapered to discontinuation so that if the patients were doing well, they would be off steroids 8 weeks after their first infusion. So it's important to understand the details of the trial. And I anticipate you'll have a lot more questions that we can address during our question and answer session. What did the patients look like? What were their characteristics? Well, the mean age of the patients in the trial was about 58. 65% of the patients were male. It has been observed across the world that patients with IgG4-related disease are more likely to be male than female. That's absolutely not to say that women can't get the disease, and there are many women in the audience who prove that. But for some peculiar reason, in contrast to most other immune-mediated diseases, IgG4-related disease is more likely to involve men than women. There were lots of Asian patients in the trial. The sites from Japan and China really weighed in big with enrollment. And of course, there were Asian Americans who were enrolled in the trial as well. Patients, about 50% of the patients had newly diagnosed disease, and about 50% had disease that was relapsing from a period of remission. The patients had very significant histories of disease, significant preceding disease burden or disease burden at the time they were enrolled. For example, 41% of the patients had more than 4 organs affected by the disease, and 43% had 3 or 4. So 83 or 84% had 3 or 4 organs affected. 100% of the patients had been treated with steroids. That has been the gold standard of treatment until very recently. And some had received other immunosuppressant therapies as well, about 13%. So this is what happened to the B cell concentrations. Inebilizumab targets B cells, and it targets B cells very effectively. The red line is the Inebilizumab group, and within 2 weeks of their first infusion, the first time their blood was tested, patients had no B cells left measured in their peripheral blood. As we discussed yesterday, patients still have B cells. They're in the lymph nodes, but they can't be measured in the peripheral blood. In contrast, the patients treated with prednisone only did not achieve B cell depletion. One wouldn't anticipate that they would. And these B cell depletion data were reflected also in the serum IgG4 concentration data. The patients in the Inebilizumab group had a slow, steady decline of their serum IgG4, and it remained low. The patients in the prednisone-only treatment group had a decline corresponding to the time when they were using prednisone. But look what happened when they got to week 8 and they stopped the prednisone. The IgG4 immediately started to go up. And then patients in the prednisone-only group were more likely to flare. They got more prednisone as well, but despite that, had an elevated serum IgG4 concentration. This was the most important curve. It's what we call a survival curve. There were actually no deaths in the trial, so it doesn't refer to a life-death survival, but it's survival in this sense means remaining in remission. So the red line shows the Inebilizumab group. Every little downward tick here indicates a patient who flared and the time the patient flared. But there were very few flares in the Inebilizumab group. There were only 7. In the prednisone-only group, in contrast, you can see there was a very steady drumbeat of disease flares. So 40 patients in the placebo prednisone group compared with only 7 in the Inebilizumab group. Unequivocally superiority for Inebilizumab, and the FDA had no trouble at all approving this drug in April of this year, and we anticipate it'll be approved worldwide over the course of this next year. With regard to adverse events, because safety, of course, impacts in a very big way our decision about treatment and your decision about treatment, Inebilizumab had a very good safety profile. The drug is not candy, as we have emphasized, and patients in the Inebilizumab group were more likely to have what we call an SAE, which is a serious adverse event. And serious adverse events have very careful definitions. So getting admitted to the hospital with pneumonia, for example, would be a serious adverse event. What was really surprising and interesting and quite a bit of relief, actually, was that with regard to COVID, there were not more COVID infections, not statistically more COVID infections in the Inebilizumab group. This was very reassuring. At the time the trial was done, vaccinations were not widely available. 70% of the patients in the trial were not vaccinated against COVID. Despite that, only 24% of the patients in the trial had COVID of any degree of severity versus 19% in the prednisone-only treatment group. So these numbers are not statistically different. So all in all, the safety profile of Inebilizumab was really excellent. So the take-home messages are that B-cell depletion was far superior to a treatment regimen of prednisone alone. There was an 87% reduction in the risk of disease flare. This was really striking. 90% of the Inebilizumab patients were able to discontinue their prednisone completely and remain off prednisone for the remainder of the trial, 90%. Only 37% of those patients who were in the placebo group, who had the short steroid taper, were able to remain off of steroids. So 63% had to go back on steroids within 1 year. And the side effect profile of INEB was very good. So this was the first randomized double-blind placebo-controlled trial in our disease. This is the only FDA-approved medication. But as I indicated yesterday, our choices are going to be expanding in the future. Within the next few months, we'll hear about the results of the Obexelimab trial, and that may alter our thinking with regard to therapy and increase the complexity of our decision making. And there are other trials that are going to be starting as well. ACE-1831 and Rilzabrutinib are starting phase 3 trials this year. So it's good news. There will be more choice in the future. There will be greater complexity. Ideally, we would like the doctors to be able to explain all this to you, but you know that you're going to have to explain this to the doctors in some ways. So this is the beginning of kicking off a conversation and an understanding about that. And with that, shall we take a question or two, or shall we go right into the clinical trial session?